Respected teachers, colleagues and friends. Both Dr. Moses and Dr. Raj are my teachers. I'm proud to share this stage with them. So next 20 minutes we'll discuss briefly about how to treat osteoporosis. What is the general guidelines? I will keep it simple. So when to treat a patient with osteoporosis? If you choose to treat, how to treat, and if you start treat, how to monitor, when to stop treatment, and if treatment is stopped, when to restart the treatment. So when to treat a patient with osteoporosis? To simply put it, when the fracture risk is high, you need to treat. So when do you say the fracture risk is high? Osteoporosis is a systemic skeletal disease when there is a decrease in bone mass and macular deterioration, leading on to enhanced bone fragility as the consequent increased fracture risk. So you treat osteoporosis when the fracture risk is high. But how do you quantify the fracture risk is high? Basically, there are three things with which you say the patient is at risk for fracture. One is when there is a history of fragility fracture, there is no need for any test. You can conclude that patient has already had an event, so he is at risk for future fracture. Or the BMD DEXA scan shows there is a bone mineral density is low but beyond a particular limit. Or you can calculate the 10-year risk of fracture. If all these things patients switch into this, then you can decide on treatment. So what is a fragility fracture? The patient has a fracture by fall from standing height or low. Just from standing in the floor, patient falls and sustains a fracture. Bone is not weak enough to fracture and the patient falls from standing height. So if that's the case, then you can conclude that it's a fragility fracture. And mostly it will involve the spine, hip, wrist or humerus. It's not, when the patient has some skull fracture or spine fracture, cervical spine fracture, it's not a fragility fracture. Only pertaining to these areas, spine, hip, wrist or pelvis. So in these conditions, you can conclude that without any test that patient has fragility fracture. In this patient, you choose to treat to prevent future fracture. That's a secondary prevention. Or the patient has no history of fracture, we can do a bone mineral density by DEXA scan, which is standard way of assessing the bone mineral density. If the T-score, that is the BMD when compared to the young age population, reference population, if the T-score is more than 2.5 standard deviation below the mean, then you say the patient has fracture. Patient is at risk for fracture. But don't jump and conclude that, don't jump and treat patient, look for any secondary causes, like it could be malignancy, something else. So rule out other causes. In this case, there is no fractures, you treat for primary prevention, prevent any future fractures. But many times the fracture occurs in the group when the BMD is borderline, that is between -1 to -2.5, that is called osteopenia low BMD. So in these patients, when do you choose treatment? So in these patients, you calculate the 10-year risk of future fracture based on a risk score. If the patient fits into the risk score, then you treat. So this online easily available risk fracture assessment tool, FRAX tool, there are specific formulas for each country. You can choose India. So if the 10-year risk of major osteoporotic fracture is more than 20%, or the 10-year risk of hip fracture is more than 30%, it will give all these, when you go and calculate, it will enter the parameters, it will give the fracture risk. So if the patient fits in this criteria, then you can choose treatment. So these are the various parameters apart from BMD which can increase the risk factor, not only BMD, so age, family history, steroid use, any other metabolic conditions like rheumatoid arthritis, etc. So all these can increase the risk of fracture, not only BMD is the main thing. So what is the definition of very high risk of fracture? Because the treatment of choice may be different. Very high risk of fracture means the T-score is less than -2.5 with the history of fracture, or the T-score is more than -3, or the patient has multiple fractures. So in this patients, mostly we choose anabolic therapy as the first line of treatment. So to put simply, when do you choose treatment? There is a history of fragility fracture when the T-score is less than -2.5, or when the patient has 10-year risk of fracture more than 20%, or hip fracture risk more than 3%. Okay, you decided to treat. How do you treat? So fracture will happen when the trauma is severe enough, like a road traffic accident, or when the bone is weak, or the patient has tendency to recurrent fall. The first one we cannot prevent because mostly it's accident, the road traffic accident, fall from third floor. Second and third point we can address. The bone is weak, you can strengthen the bone with various medications. The patient has tendency to fall, very common in old age, you can do various fall prevention measures. So how to treat gentle measures and specific drugs? So gentle measures is standard for every patient. Adequate intake of calcium, vitamin D, exercise, which will strengthen the muscle, improve the balance, prevent falls, smoking, alcohol cessation. Mainly, this is very important, maybe a simple thing, counseling on fall prevention. Most common reason for a fracture in old age patient is they fall in a bathroom, either due to slippage or lack of light. So, need to have counseling regarding various fall prevention measures and avoid drugs which can increase the chance of fall, like sedatives, diuretics, etc. And try to minimize the drugs which can increase the bone loss, like steroids, etc. So, what are the drugs available for osteoporosis management? There are two groups. One is anti-resorptive and anabolic drugs. Commonly used anti-resorptive agents, one is the bisphosphonates, second is denosumab, that is rank ligand inhibitor. Other things like HRT or Luxevin you don't commonly use. HRT is mostly used when the patient is very young, premature menopause. In postmenopausal age, generally we don't use HRT or Luxevin. So it is mostly bisphosphonates or denosumab, that is anti-resorptive agents. And anabolic we have most commonly used is teriparatide. We also have abaloparatide and romosumab, which is the latest one in the armamentarium, sclerostin inhibitor. So how do you choose among various drugs? Again, it's not a straightforward thing. It depends on the efficacy of the drug, safety, cost. Cost is a very important factor because many of the drugs may be made costly, patient may not afford. Convenience, whether the patient prefers injection or tablet, and the individual fracture risk, whether the patient has low risk or high risk, etc. So, in general, the first line of treatment is mostly bisphosphonates because there's a long track record and it's very cheap among all the drugs, and it can be used up to 6 to 10 years. So, commonly used bisphosphonates, one is alendronate, which is oral thing, which you give it 70 milligram once a week, or IV zoledronate 4 milligram or 5 milligram as infusion once a year. These two are the commonly used bisphosphonates. We also have risedronate or ibudronate, but these are two are the commonly used ones. So, when do you avoid these drugs? Oral bisphosphonates you generally avoid in the patient because this can cause a lot of esophageal irritation. You avoid it when the patient has esophageal disorders like achalasia cardia, some esophageal varices, Barrett's, etc. And the patient has to be sitting for at least 30 to 60 minutes after taking the drug because the patient lies down immediately, it can cause esophageal irritation. So, in bed-bound patient, you should avoid it. And post-Barrett surgery also better to avoid these drugs. And both IV and oral you should avoid in patient with CKD. The GFR is less than 30. As Dr. Shuri has mentioned, when you give this anti-resorptive drugs, patient is at risk for hypocalcemia. So, if the patient has hypocalcemia, routine deficiency, better treat it before starting the therapy. And they can also at risk for jaw necrosis. So, if there are any dental problems, address it before starting treatment. So, second anti-resorptive agent which is used is mostly this is second line drug. First line will be mostly bisphosphonates. And the bisphosphonates cannot be given mostly in the most common group will be CKD patients where we cannot use the bisphosphonates. This will be a second line treatment. This is given as IV injection once in 6 months. And also it can be given for 5 to 10 years. But main problem with this drug is that when you stop this medicine, patient will have rapid bone loss. So there will be rebound increased risk of osteoporosis, which is not the case with alendronate or zoledronic acid. So when you stop this drug, there should be alternative medicine. Otherwise, patient will be rebound risk of fracture. So as I said, in this very high risk of fracture, that means when the T-score is minus 2.5 with fragility fracture, or the T-score is less than -3, or there are multiple fractures, you choose anabolic agent as the first line if the patient can afford. So most commonly used drug is teriparatide, which is a PTH analog. Other two drugs are also in market, but most commonly used is teriparatide. So teriparatide can be used up to 2 years. Beyond that, it's not approved. So it is given as a sub-Q injection once a day. But when you stop this agent, you should replace it by anti-resorptive agent. Otherwise, they can rapidly lose the whatever gain was there with the anabolic agent. So mostly used for 2 years and then replace it with the zoledronic acid or alendronate. Or if the patient cannot be given bisphosphonates, you can give denosumab. So this is the latest one, romosumab. It has come into the market but not routinely used because of cost and availability. The increase in bone mineral density seems to be much higher than the PTH, but there are some cardiac safety issues is there. We need more data, I think, but it's approved from 2019. It is approved for usage up to 1 year, once a month injection. Again, like similarly to PTH, you need to start anti-disruptive agent when you stop this medicine, otherwise patient will rapidly lose the whatever gain was there during the usage of the medicine. So what are the drugs to be avoided for treating osteoporosis? Calcitonin is a very weak agent. It is not routinely used for treating osteoporosis. Mostly it is used for pain when the patient has acute spine fracture. Again, calcitriol should not be used routinely for treating osteoporosis. Calcitriol should be used only in specific settings like hypoparathyroidism, CKD metabolic bone disease, and specific cases of rickets. Calcitriol should not be used routinely because it's a short-acting agent that can risk for hypercalcemia. So it should be avoided. Strontium, it's now not the market. Again, it should not be used. Tibolone, it should not be used because there is increased risk of venous thromboembolism. Fluoride should be avoided. And this agent has been in the many of the pharma are marketing this agent, vitamin K analog. It is based on one study from Japan, but there is no consistent benefits from other studies. So this should not be used as a primary agent to treat osteoporosis. So we have started treatment with one of the agents. How to monitor the efficacy? So monitoring response is important because all the patients are not going to respond uniformly to the treatment. Up to 1/6 of the patient taking alendronate may not respond to the patient. They can continue to lose bone. So you should know when the patient is responding, when the patient is not responding. Again, there is no universal consensus on how to monitor, but there are general guidelines, and also monitor for adverse effects. Most important thing when you give long-term drugs is the compliance. Many patients, when you give alendronate, they are not able to take it, so check for the compliance. Clinical assessment, look for any new fractures, look for side effects like osteonecrosis of jaw, atypical femur fracture. Many times the spine fracture is asymptomatic, so you can check a spine X-ray to look for any new fractures. Then two most important investigations are serial DEXA to assess the improvement in bone density or bone turnover markers. So DEXA scan, what is the optimal frequency? Again, between 1 to 2 years you can repeat it if possible. So mostly we do it after 2 years or maybe after 3 years also. It is important to do in the same machine because it cannot be compared when it's done in different machines. So a change in BMD is considered significant when the change is more than the least significant value that machine will give. If it is not there, you can take it as only 5%. So if there is an improvement by more than 5% or loss by more than 5%, then you should take it as significant. It's not the T-score, you have to look at the actual bone mineral density values. So second important thing to monitor is the bone turnover markers. Again, it's an evolving thing. The guidelines have not incorporated in the bone turnover markers in the specific treatment modalities, but it's upcoming. So you can look at one turnover marker for bone formation, one turnover marker for bone resorption. There are no prospective trials to look at what is the cutoff and when to stop treatment based on these markers. Nonetheless, it can be useful. It can give a guideline whether the patient is responding or not. So PINP used for bone formation and CTX used for bone resorption. The values are consistently elevated. Either the patient is having some complaints issue or the drug is not responding. If it is suppressed, then you can take it that the patient is responding well. Or if it is very much suppressed, the patient is at risk for adamnic bone disease. Then we have to stop treatment for some time. So when do you say treatment is effective? There are no new fractures. BMD is stable or improving. Again, this is important. Many times the patient will ask, the T-score was minus 2.6, now also is minus 2.6. That shows it's an improvement because there is no loss. So stable BMD itself shows that patient is responding or the BMD is improving. However, there is no 100% correlation with BMD and the response to alendronate or zoledronic acid. Some patients may respond even when the BMD is low. Some patients may continue to have fractures even when the BMD is improving. So there may be other factors also. So we can look at the bone turnover markers also along with the BMD. The BMD bone turnover markers are remaining low, that means patient is responding. So when you say that treatment is ineffective, when there is no new fractures are occurring, or when the BMD is showing there is loss of bone mineral density by at least more than 5% or above, or the bone turnover markers are consistently elevated. It could be either due to compliance or drug is not effective. So you choose to treat the patient. How long to treat? These are not like diabetic medicines or anti-hypertensive medicines. It's only for a specific time. So when to stop, and when you stop, when to restart. So how long to treat? Mostly we'll go with the bisphosphonate, that is the most common drug. In general, it is used for 3 to 5 years. If it is zoledronic acid, you give for yearly once for 3 years. If it's hyaluronic acid, you give for 5 years. After that, you assess the patient. You look at the fracture risk. If the fracture risk is low, then you can stop treatment for some time. The fracture risk is high, then you continue for 6 to 10 years. Because you have to balance the risk versus benefit. Long-term treatment with these agents increases the risk of atypical femur fracture and osteonecrosis of the jaw versus the benefits of fracture prevention. So you cannot continue for all patients. So after 3 to 5 years, look at the fracture risk of the patient. So if the BMD is stable, there is no loss, there is no new fractures, and there is no previous history of fracture. In this, you have started the treatment in patients with no previous history of fractures. So in these patients, you can stop after 3 to 5 years because the bisphosphonates have residual benefit. It can persist up to 5 years, can show in the studies. And you assess if the patient has high risk of fracture, that is, you have started the treatment because there is a past history of fracture. That means patient has tendency for fracture, or the T-score is less than -3 or in the absence of fractures. Then you have to continue for up to 10 years or 6 years. If it is hyaluronic, you have to continue for 10 years. Zoledronic acid, you have to continue up to 6 years. Beyond that continuing, there is no data, and there may be excessive risk for aerodynamic bone disease. Denosumab also is saying there is data up to 5 to 10 years. So you have stopped treatment, when to restart. Again, there is no clear-cut guidelines. This is called drug holiday. You interrupt the treatment for between 3 to 5 years. In this time, you continue to monitor the BMD and the bone turnover markers. Restart the treatment after 3 to 5 years if there is a drop in the BMD or persistent rise in the bone turnover markers. So you repeat the BMD after 2 years. If there is a drop by at least 5% or more, then maybe you can restart the treatment. Or there is evidence of a drop in the BMD along with persistent elevation of the bone turnover markers. For example, CTX, if it's above the above the limit of the age, that is more than 600, then you can start treatment. Because that means the patient has increased resorption at risk for future fracture. If not, you can keep following the patient for next 10 years. With this, I will stop. If there are any questions, we can take.